All right, well, welcome everybody. I think we're going to go ahead and get started. I know a lot of people on this call, but if I don't know you already, my name is Sally Safi, and I'm the Director of Graduate Studies in the Department of Population, Family, and Reproductive Health. And I've also had the pleasure of advising some of the students who will be presenting today. And it's been a real pleasure working with them for the past couple of years. So today we will have 4 presentations by students who will talk about their master's essays. Each student will have about 10 minutes to present, and then we'll have another 5 minutes for each person to do some Q&A. So thanks to all of your presenters, for all of the presenters for being here today. We're really excited to hear your work. And I also would like to thank all of your faculty essay readers who are also on this call and helped guide you through this process. So first up, we have Alena Pappas. Alena has a bachelor's from the University of Arizona, where she majored in public health, and she will be presenting her essay about comprehensive sex ed in the US. So Alena, welcome, and would you like to share your screen?
Yes, absolutely. Give me 1 second. All right, does that look okay to everyone? Awesome.
Looks great.
Thank you, everyone. Good. Thank you, everyone, for joining. My name is Alena Pappas. I'm going to be presenting my master's thesis, which is an assessment of the influence of comprehensive sex education programs on public school students in the United States. There are 2 objectives of my assessment. The first one is to critically examine the impact and implementation of comprehensive sex education, which I will be referring to as CSE throughout this presentation, in public schools across the United States, and to recommend key action steps to ensure adolescents receive necessary information for health and safety. Why schools should implement school-based CSE? Research has demonstrated that CSE can reduce sexual activity, reduce pregnancy, reduce STIs, reduce homophobia, and improve academic success. Adolescents spend a great deal of their time in school and are grouped within schools by age or development level, which makes it a little bit easier to implement this education. Schools also have more regulations in place, which offer more opportunities for accountability and support. So as of February 1st, 2023, 38 states and the District of Columbia mandated sex education and/or HIV education. And of these 38 states, 26 of them mandated sex and HIV education, 2 mandated sex education only, 11 mandated HIV education only, 17 mandated medically accurate content, 27 mandated age-appropriate content, 10 mandated culturally competent content, and only 4 prohibited religion promotion. How legislation affects outcomes of adolescent sexual behaviors. So adolescent STI rates are lowest in Vermont, New Hampshire, Maine, West Virginia, Utah, and Idaho. And with the exception of Idaho, all of these states mandate sex education. A typical state sex education mandate increases adolescent condom use by 3% and decreases teenage chlamydia rates by 8%, which can result in $43 million in savings annually for STI care costs. And lastly, Oklahoma is one of the states where students are taught that homosexual behaviors are the primary cause for HIV and AIDS, and it has the highest rates of LGBTQ plus students who reported being bullied at 48.3% in 2017. So these are only a few statistics, but there are many, many more that show the outcomes of this legislation on adolescent sexual behaviors. There are only 2 federal funding streams for evidence-based medically accurate sex education. The first being the Teen Pregnancy Prevention Program, which works to build an evidence base of effective sex education programs by supporting the implementation and evaluation of evidence-based programs and using innovative approaches to reducing pregnancy among adolescents. The second is the Personal Responsibility Education Program, which is not comprehensive and emphasizes abstinence and contraception with a variety of evidence-based programs that aim to prevent pregnancy and STIs among adolescents aged 10 to 19 who are homeless, in or aging out of foster care, living with HIV or AIDS, victims of human trafficking, or living in areas of high adolescent birth rates, as well as people who are pregnant or parenting that are younger than 21 years old. While CSE has been proven to be effective, there are currently no federally funded programs dedicated to funding and expanding access to CSE. Efforts to implement CSE have been unsuccessful across many states and school districts, and this is for several reasons. The first being that there are many political agendas of specific organizations, such as Focus on Family, Citizens for Excellence in Education, Concerned Women for America, the Christian Coalition, and the National Coalition for Abstinence Education, which is done by packing school boards to control decisions that promote abstinence-only education. The next is teachers' attitudes and readiness to deliver CSE effectively are common barriers, along with parents' lack of cooperation and the overall lack of desire for CSE to be implemented. There are also systemic challenges related to human and financial constraints, unstable infrastructures, competing priorities, weak coordination and collaboration at local, regional, and national levels, and all of these prevent CSE from being implemented. Despite school-based CSE being the best route for educating adolescents about sexual and reproductive health, it can sometimes be the least accessible and feasible option. Other options for educating adolescents, even though they are maybe less favorable, include training parents and other caregivers to discuss matters about sexuality and reproductive health. A pro of this avenue is adolescents who reported receiving sex education from parents were more likely to report having a later sexual debt, reduced number of sexual partners, increased contraceptive use and condom use, and more negative use of pregnancy. A con of this is that parents or caretakers may not have the complete medically accurate information needed to educate their children, and they also may not feel comfortable discussing these topics with their children. In addition, there is also digital and social media, which can serve as a platform for executing innovative, scientifically and medically accurate sex education to diverse groups of adolescents, including sexual minority adolescents. A pro of this avenue is that it offers anonymity, which can be a safe place for adolescents to explore these sensitive topics in a discreet and independent manner. And a con of this is that there is the possibility of spreading inaccurate or harmful information since social media or digital media is not as regulated or monitored. So how do we work towards getting CSE implemented? The first step is eliminating abstinence-only education programs, which have been proven to be harmful and ineffective. Next, we can fund CSE programs. Policymakers need to work towards funding acts such as the Real Education and Access for Healthy Youth Act and promote acceptance of CSE. Educating others on the importance of the scientific evidence behind CSE is one of the first steps. And working with local non-governmental organizations, policymakers at the state and municipal levels, and building multi-sectoral support by convening representatives in different sectors. I now want to provide a huge thank you to my reader, Kristen Mari. I could not have done this without her. She is a blessing, as well as my advisor, Sally Safi, Kristen McCormick, the Pop Fam cohort that's graduating this May, and all of my friends and family. I could not have done it without their support as well. So thank you so much. Here is my contact information if anyone needs to email me about anything, and I am now open to any questions or comments.
Excellent job, Alena. Feel free to come off of mute if you have a question in the audience or type it in the chat, and we'll prioritize student questions first. Yael?
Yeah, great job. I have a quick question. Do you have any personal experience teaching sex ed, or can you talk a little bit about that?
I do actually. So my first time teaching sex ed was to low-income students in Nogales, Arizona. It was very interesting being able to teach these students and seeing how open they were to learn this information. And I also had the opportunity of being a Planned Parenthood intern within this as my placement for this program. So it was also very interesting seeing the differences between teaching in Arizona and teaching in Maryland, and seeing how the students reciprocate the information and seeing what they do know and what they don't know. Especially, Arizona is not a state that mandates sex education versus Maryland, I believe. can't remember how much they mandate, but I know that they mandate more than Arizona does, but it's still really, I guess, interesting. I'll use that word again, seeing the differences in where they do teach it versus where they don't, and seeing all of that. Thank you.
Great, thank you.
And I see 2 more hands. I'm going to take the student question first, and then we'll go to our Jamila.
Hi, my question is, do you feel abstinence teaching styles are ever going to go away from the way we teach sex education inside the United States, given all the things that's currently happening with sexual reproductive health rights inside the United States? Thank you.
A really good question. I would really hope so, but just like you were saying, with like kind of like the political climate of things right now, and especially the attacks on LGBTQ people and students in particular, I think right now it's probably not feasible, unfortunately, but I really do hope for the sake of adolescents that it is eliminated one day.
And Arik?
Hi, I'm Arik Marcel. I'm faculty in school of medicine and in this department. What a great talk and overview. I wanted to ask you if you came across any literature that looked at, so there's a particular series called the Amaze series. It's a free website-based kind of short videos covering, comprehensive sex ed, and the degree to which kids are able to access it, especially in states where they're not getting it in the school, and dissemination approaches, right? The ability to think about different ways to get content to kids and their parents separate from schools, which may create barriers for teaching it.
So I actually have heard of the Amaze series. I think it's a fantastic series. I actually attended a sex ed conference in 2018 and 2019. And they actually had a whole session on how we can make this information more accessible. And I was still an undergraduate, so I don't think I was like fully understanding everything at the time. But now that I look back on it, they were creating some really innovative ideas of how that they can implement it even into their classroom without breaking policies or those kinds of things, or creating like social media pages that they can share this information with their students, or letting parents know about it so that they can educate themselves and then further educate their students. And did I miss a part of your question? I might have. Thank you so much.
All right. Amazing work, Alena. Great job. Thanks so much for presenting and taking those questions. We're going to go next to our next presenter, Jamila Asker. Jamila has a bachelor's from Georgia State University, where she majored in public health. And today she'll be talking to us about measurement of contraceptive preferences. So Jamila, take it away.
Can everyone see my screen good?
Yes, you're not in presenter mode yet, but you can see your screen.
Sorry. Okay, hello everyone. Today I'll be talking about a scoping review on the measurements of contraceptive preferences. So a little background, in the 2022 State of the World report by UNFPA, it was estimated that 250 million women wanted to avoid pregnancy, but were not using any safe or modern method of contraceptive. And out of those women, 172 million were not using any method at all. So traditionally, we thought about low intake as a way women not having access or knowledge about contraceptives. But this new report really shows us more about concerns about side effects, myths, stigma, and opposition from others. Sexual reproductive health is a right. And we have to start shifting from these ideas of program-centered metrics like usage and kind of shift towards patient-centered metrics to really ensure that women are getting the contraceptive needs being met. This really includes making sure women are getting contraceptives that satisfy their preference. So what is the concept of contraceptive preference? It's really the contraceptive method a woman prefers, and this is not the same thing as usage. The problem becomes a lot of people started looking at contraceptive preference, but not really understanding what it means and how do we measure it. So that's where the scoping review comes in. We're trying to identify and summarize studies focused on measuring contraceptive preferences in low and middle income countries together as one group versus high income countries. The methods. So like I said before, this is a very new concept. So there's not really a key term that's used for contraceptive preferences. So we had to use a lot of interchangeable terms like ideal, most wanted, and things of that nature in that chart to show preference. And we had to add these in combination with methods of contraceptive and attributes of contraceptives. And I'll explain why those two categories a little bit later. So we had to use contraceptive and family planning as mesh terms because without them, we would get similar topics like fertility preference, but that's not really what we were looking at. Of course, all the articles had to be peer reviewed, involving humans, and after 2000s. So here is the screening process. We started out with 4,401 articles from PubMed. We used the app Covidence that took away all the duplications, and we eventually screened down to 111 articles. A bunch of articles had to be excluded because of things like not finding the full text, not being the target population. Instead, they really looked at like providers' preferences and not patients' preferences. A lot of articles that were taken out were not applicable to the question. This encompassed a couple different things. One, they were looking at usage, but they used the word preference. Two, they looked at contraceptive care preferences and not contraceptives themselves. And lastly, they looked at one specific type of contraceptive, and we felt that was not really good for this particular scoping review. And of course, gray literature and literature reviews were removed, leaving 49 articles. So I talked about those two categories a while back. The reason we had these two categories is because they're the two types of ways you can approach it. Directly, which is you directly asking women to report on their preferred method, and indirectly, which is a little bit more complicated. You're asking women to report on attributes or characteristics of contraceptives they like. Think about the reasonings they chose these contraceptives. Majority articles either fell into either or category, but there was a few that used both of these approaches. So here are all the results of the number of articles. The things I really just want you to focus on is the bolded. So direct was the least amount with 14, while indirect was the bigger amount. We also had on the bottom, if you see the number 3 and 2, those two categories were methods that use both approaches of indirect and direct to look at contraceptives. So kind of focusing on indirect, we're going to shift to looking at the different types of articles and what they did. So there's 18 articles, and this 18 number also includes the 5 articles that use both methods. Looking at this chart down here, they use the word preference only 6 times, 6 different articles. Instead, words like ideal, satisfied, and all other type of wording was used instead to kind of have this idea of preference inside of the questions. 3 articles use different ways, and I'll show examples of all of these in a second. Next, it was longitudinal studies were not a lot of them. Majority were cross-sectional, and a few were using electronic health records. Moving back to these questions, some of them add in things like barriers and costs when it came to asking directly these women about their contraceptive preferences. Sounds like a lot. Here is a lot of words. You don't have to read them. The things I want you to focus on is these bolded aspects. So you see wanted, most like to use, could use any birth control, ideal choice, how do you feel? There's so many ways they ask this idea of preference. And some of these articles also use the barriers, like I was saying, regardless of cost or other difficulties. All of these questions are looking at preferences, but they're asking in multitude of ways. The last article on the bottom kind of is that special category that looked at women post-abortion, and some of postpartum articles also did this as well, and asked them what method would you like to use, and later compared it a couple months later to see if these women were using these methods. So indirect, this is thinking reasons, attributes, things of that nature of why women choose certain contraceptive methods. This was the most category. The previous category was all quantitative, while this one is a mix of qualitative and quantitative. These numberings are not going to add up together to be 37 because many of these articles use focus groups with cross-sectional surveys. So thinking about these features, functions, attributes, so many different words to really describe the reasons why women choose these different contraceptives, There are so many within 37 articles. So instead, we kind of group them into categories. These are the categories listed on the bottom. I want you to focus first on other category. This other category was all the other types of contraceptive preferences and attributes that were not listed that could fit in these categories. These are all the times they're mentioned within each article of these categories. Side effects is another one I want to focus on. Side effects, we had specific side effects mentioned in a lot of articles like pain, menstruation effects. So these were put into subcategories to show an emphasis that not only are women thinking about just side effects in general, they're thinking about certain particular side effects that they have dealt with in the past. So the discussion and conclusion. First off, a lot of articles still think preference and usage are the same thing, and that's something that needs to be addressed. The second thing really is there's no standard way of measuring contraceptive preferences. We saw this in direct and indirect, with indirect having so many different wordings to ask that direct question of what type of contraceptive would you like. Indirect, we saw this with how many attributes were listed even after being put into categories. So it brings up the question, should we be developing a guideline to measure that? And lastly, there's also this idea of positive and negative toning when it comes to the standardization. There was a lot of different ways attributes and even questions were toned, which can really affect how a woman answers these questions or choose these attributes. And those should be a little more research into. Lastly, really, it's under research, especially in low middle income countries and upper middle income countries. Most of the research is in high income, especially the United States. And regions like South Asia and South America are highly underrepresented. Thank you so much. If you guys have any questions, I am free to answer them. And I just want to say a special thank you to my reader, Carolina, for helping me and supporting me with all the work this took. Thank you.
Great, excellent work, Jamila. You did a great job of putting a ton of information very nicely into a nice presentation. So thanks for that. Again, we'll take some questions. Any student questions? Alena?
Hi, yeah, great job, Jamila. That was wonderful. I was wondering if you could talk a little bit more about the negative and positive toning aspect.
That's a great question. So focusing on attributes, for example, we had attributes thinking about effectiveness. Some of these articles said they would have quotes for women to choose, things like, I want the most effective contraceptive, or something that is least effective. And that's very confusing when you compare it to an article that says effectiveness as a neutral tone. So these two different types of, which I would say toning, is just very confusing. Same thing with fear of side effects, not wanting side effects. It just varies a lot how they write down these characteristics about these attributes. Thank you.
Yeah.
Yeah, I think my question, great job, by the way. I think my question, kind of going off of the toning, was if you could explain just a little bit more about that attribute aspect, like how you created those attributes.
Perfect. I have a slide in the appendix kind of giving, okay, so this is a lot of words, but what happened really was we looked at, here's two examples from the actual presentation. It had themes, and it would say perception of larks being too long. Well, these characteristics, this is a lot to read as a person, and it wouldn't be beneficial for me to just give you all of these listing, because you would have to think about it and say which one of these would compare. So what I did is I can get pregnant immediately after stop using. I thought about it, compared it to a lot of different articles, and when it came to these different, these are all the attributes broken down. When it came to these different things, number 16 is fertility reversibility. And this is just focusing on anything that has to do with fertility. It was difficult to really put it into a bunch of categories. Sometimes they didn't fit into any category, and that's why the other category fit. Things like life course perspective or how old a woman is, that fell into the other category because it really didn't fall into like ease of use, which would be like maybe how do I apply this method? I hope that could help. I know it's a lot to read and a lot of attributes written down, but in general, I can definitely send this list to anyone if they're interested a little bit more.
No, definitely. It was really thorough. Thank you.
Thank you.
I'll ask a question. After all of this work, you know, on your discussion slide, you mentioned that there is no one standard measure. And do you have any ideas if you could add like 1 or 2 survey questions to large scale surveys? What would you ask? And like what would be most useful in terms of like what data do we need?
I think that is a great question. I think it's a mix for when it comes to things like the broad family planning surveys that are done in a lot of countries, just asking which method do you prefer when it comes to contraceptives might be helpful. It also might be helpful to add in that aspect of barriers, regardless of cost or regardless of barriers, because we can know a little bit more about what women want. When it comes to surveys really focus on just preference and usage in general, because we're trying to address those things like side effects that people are concerned about. It might be a little more beneficial to have those attributes listed into questions, or having a lot of these articles did a very interesting thing when it came to cross-sectional surveys. They had women take discrete choice experiments where they gave women scenarios and said like, which one of these attributes would be the most important thing in this scenario? And that really helps shape like figuring out what a woman really prefers when it comes to contraceptives. Another thing, sorry, I'm giving so many different answers when it comes to this, but another thing is there's a few things called like choice experiments. I'm not entirely sure. It's choice. I remember the last word after it, but these are being done now in clinics that they'll give women these kind of questionnaires. And after they fill out these questionnaires, the women would know what preference, what their preferred method is. And having things like this being standardized in clinics make it a little easier. So when we ask that question of, you know, which method do you prefer, they actually know, and it's not based on having a low education of, oh, my doctor told me this, or this is what I think it is.
Great, thanks so much. I think this is really important work in terms of upholding reproductive health and rights. So thanks very much again. Great job.
Thank you.
And we'll move on to our last presentation. We have Yael Hamburger, who went to the University of Maryland College Park and majored in family science. And today she'll be talking about a y2connect.org Baltimore. So I'll turn it over to you.
Great. Can you see my screen?
Yep, it's perfect.
Hi everyone, my name's Yael, and today I'm going to be presenting my master's thesis on a project that I've been working on with Dr. Marcel called Y2Connect. So during this presentation, we're going to talk a little bit about what Y2Connect is and how it really addresses a critical need for adolescents when it comes to accessing resources and services here in the Baltimore community. So as I'm sure a lot of us know, adolescence is really a critical developmental period. It's a time when individuals finish their education, they begin working, they develop relationships, and they really begin making more of their own decisions. It's also a time where they need more support from across a variety of sectors. And when I say sectors, I mean education, employment, social, civic, and health sectors. That being said, adolescents and the individuals that care for them often aren't aware of the local resources across these sectors. For the resource guides that do exist, they can be helpful for connection, but they tend to only focus on a single topic. They tend to be in paper formats, they're potentially outdated, and they also tend to be population level focused, so they really aren't specifically for local communities. So from this, we see that there's a need. There's a need for a technology-based solution which could really provide easy access to adolescent-focused cross-sector resources. This is where Y2Connect comes into play. So this is a website. It was launched in 2016, and it was developed in Baltimore as a technology-based solution to improve the transparency of adolescent-focused cross-sector resources. Because it's a website, it's free, it's mobile-friendly, it's really comprehensive, and it's available to anybody who wants to access it, and also serves as an educational hub for any users. And here's a screenshot of the site. So the purpose of this study was to examine, since its launch in 2016 across a 5-year study period, both trends in usage over time, as well as engagement and viewed content, as well as if this content viewed was across sectors. So we'll take a look at a few of those things. Here's another screenshot of the site itself on the left. And you have the option to choose from one of 10 domain pages when you get onto this screenshot. There's also a zoom in on the bottom where if you click view all resources on the page, this brings you to a page of the listings of all 50 resource categories. There are also separate links. You can see, I know it's kind of small, but in the upper left-hand corner, this red circle for informational pages for adolescents, not only, but also their parents and other professionals that are serving them. And then there's also this text box which you can see with the arrow here, where users can search the site by typing in free text or zip code directly onto the site. So let's take a look at this birth control page, for example. You can see each of the listings viewed under here, and it's under one of 50 pre-organized domain pages that we just saw on the previous slide. Each of these listings is categorized as one of 4 different resource types. So we have clinic, which you can see here, community resources, hotlines, or websites. So on this screenshot here, you can really see that these first 2 listings are clinics, for example, because of the logos listed next to them. So switching gears from the site itself to our actual study, we use Google Analytics to analyze all of our data. So each of these measures that you see on the screen here are standardized measures. So Google Analytics really provides this to us for free. So we're really able to take advantage of this for all of the data analysis for our study. So these measures, as you can see, include total number of users who visited the site, the number of unique sessions a user made, total page views, average session page view per user, mean session duration, percentage of new sessions, and then exit and bounce rates. So exit rate here is defined as the proportion of sessions ending on a given page. And then we have bounce rate, and that's the percentage of single session users who visited the site and then bounced, or they left the site without further interaction. So some of the other measures that we used, again, provided directly to us from Google Analytics, included device usage, acquisition source, geography, language used, as well as age and sex demographics. And it's important to note that these were only for people that were logged into their Google accounts and aged 18 and up. So we then analyzed the data for each of these study measures that I just listed. So using Google Analytics, again, we were able to filter the data to ensure that users were only viewing the site in English as well as in the US context. So with this, we were able to identify over 65,000 users, and we then tabulated that data by user engagement, demographics of the users themselves, how they access the site, and overall viewed content, along with the other measures that I just described. So we then created codes, and we created these codes to categorize all of the content viewed. So we took each of the 50 pre-categorized domain pages, which you saw a few slides ago, and we put them into 21 subdomains. And then for those 21 subdomains, which we'll see in a little bit, we put them into 5 sectors, and I'll go into that. We then coded each viewed listing according to a coding scheme, and we had 97% agreement between 2 coders. And we also conducted linear regression to examine this use over time. So for our results, let's first take a look at the user engagement. So what are these users? Users made over 73,000 page sessions with over 114,000 page views. In terms of how these users access Y2 Connect, more than half of them used it on their desktop, as we can see. And a majority of the site visits were organic, which means they clicked on our site as a result of typing into a search engine. So for example, Google. Now looking at this user engagement, but over time, through linear regression, we were able to find significant average increases in both new users and sessions. And you can see that on the panel here up top. And on the panel on the bottom, panel 2, we were able to see the average increases in users overall. And this is for both males and females, ages 18 to 24, compared to all other age groups. So now that we've seen these trends over time, who exactly are these users that are using the site? Looking at user demographics, they were mainly from Baltimore and the surrounding areas, more than half, and they were young adults ages 18 to 34, as well as identifying as female mostly. Now let's take a look at what these users are actually viewing on the site. So as we can see here, these are the proportions of page views across the site as a whole, and N at the top here in blue are the total number of page views that we had. So the highlighted rows here represent the most commonly visited pages. So most users visited the preset category pages when they landed on the site. And then upon further exploration, when they found different resource guides, they chose local community resources. And then as well as article pages were really highly viewed content. So in the next few slides, I want to take a minute to talk through each of the 5 sectors and the different resource types within those sectors. So you can see the sectors here on the left, and we're going to go through them one by one. And the 21 subdomains are next to these sectors. You can also see on the right-hand side here, each of the 4 different resource types that I described before: community, website, hotline, or clinic. So starting with the health sector, we can see that the top 3 most commonly viewed areas were family planning, youth-focused clinics, and mental health. And this made up almost half of the viewed content across these sectors. So a really big portion of this was in the health sector. So let's take a look at our next sector, which is school and job, and that includes school readiness, STEM, and job readiness, and that was at 16% of the content viewed. We then have social service and recreation as our third sector, and that includes youth volunteer opportunities and youth development programs at 13%. We then have specific populations, that's our fourth sector, and LGBTQ plus content was commonly viewed, and interestingly, the hotline was a big part of that. And then our fifth and final sector was essential services. And when I say essential services, that means everything like clothing, laundry, food, income, life skills, everything like that is really encompassed. So as we can see here, these are all the sectors, and we see that overall users were really viewing the content across sectors. So in summary, these findings really highlight the importance of a comprehensive cross-sector adolescent-focused resource guide. This website serves and continues to serve as a one-stop shop for users to really be able to access information across content type and sectors, and we can see that Google Analytics was really helpful as a data analysis tool. In terms of limitations, one of the main limitations we came across was the US context. So we did restrict it to English and US. That could have removed US users that were potentially logged into another country by mistake, as well as it was measured by IP address. So perhaps if somebody was logged into a computer, they had the same IP address, they were sharing computers, that could have really altered the user results. In terms of implications, Y2 Connect has the potential to be a really helpful technology-based solution for increasing adolescent connections to local cross-sector resources. So we really need to examine the benefit in other cities and in other jurisdictions where this could be beneficial, as well as to see if the use of this site actually results in actual connectivity to care providers and other services in Baltimore, as well as seeing how Google Analytics can help inform public health measures in the future. I'd like to take a minute to just pay attention to the co-investigators and the funding support by the CDC listed here. And then acknowledgements. I wouldn't be here presenting before you today without the help of so many people. So Dr. Marcel, your guidance, mentorship, and support for the past 2 years have been truly incredible. You've helped me grow so much throughout my time in this program, both in and out of the classroom, and have provided me with opportunities that wouldn't have been possible otherwise. I also want to thank my advisors listed here and the whole PFRH department, colleagues, and friends who have supported my learning experience here at Bloomberg and me personally throughout the program. And last but not least, to my family and my partner for their unwavering support and confidence in me always. References. Thank you.
Great, excellent work. Amazing job putting all of that information into that very concise and great presentation. Who has questions? Tiffany.
Hey guys, so Yael, great job on your presentation. It's really great that you talked about the Y2K. But I also wanted to ask, did you have for your Google Analytics, did you have any users, any data for users that were less than 18?
Yeah, so we actually did not have any data for users less than 18 because Google Analytics works in a way where it doesn't provide any data for those under 18. We weren't able to get that. I will say that we did have a pop-up on the website. So a lot of times there were students that needed to go to Y2 Connect for a school project or something. So we could kind of tell if there were students, they could mark that they were students on the form. But no, because we weren't allowed to get any demographic or user information, it only logged or tracked those 18 and up. But
Shoshana?
That was an awesome presentation. Great job, Yael. I was wondering if you could talk a little bit about how Y2 Connect gets updated. I know you said it was up to date at the beginning, but how frequently does it get updated and how might that impact kind of how adolescents interact with it?
Yeah, that's a really good question. So it gets updated annually. So we have a team of us that goes through and we have a whole spreadsheet and we're able to kind of keep track and keep up to date with all of the resources. And that includes calling and emailing all of the listings that are on the site to make sure they're up to date. So it is a kind of cool process to be able to make sure that everything is up to date on the site annually.
I can go then. So thank you so much. This was so great. I know this because I remember when Eric first showed this to me a while ago, and it's just so fun to see how this has grown. So great job. I'm just wondering, like, what are the next steps for this? So I noticed females, for example, are using this more. Are there plans to market this to other areas to increase, or is it just by word of mouth? So that's one issue I have. And then, yeah, well, let's just stop there.
Yeah, so that was kind of another thing that we were focusing on. I think originally when we were talking about doing this and kind of what to focus on, we were thinking of scope. And so I think we were just trying to figure out trends in usage over time, but it's definitely important to think about how else to disseminate the content. So I think a big part of what we are thinking for next steps is creating a dissemination plan and how other resources or listings or organizations who might not even be aware of Y2 Connect really are. So I think that includes reaching out to people here at Hopkins, but also other local universities and any other nonprofits and organizations that maybe they are more recently created, because this was launched in 2016. So it was an older site.
Yeah. I mean, we could help. So, and then I guess one more little thing is just, is there plans to find out if they actually used some of the resources? So it's one thing to like, they're on the website, but, and I don't know, like, is that of interest to the team, or is that, what are your thoughts on that?
Yeah, so we've talked about that as well. I think it definitely is of interest. It's just harder to track that. So I think one of the benefits of this was that Google Analytics gave us all of the measurements that we needed for this particular aspect of the study. But we are really interested, and I think it's kind of difficult from our perspective, knowing, okay, these users are accessing this information, but are they actually following up and going to the so it is a really good point, and I would be interested to see if there would be something that we could do follow-up wise. I think it's just a bit difficult, also because the people hopefully accessing this site are under 18, and we don't have the demographic information for them. So yeah.
Well, great job.
Thank you.